when we think about GIST and the landscape of GIST, I mean, I've been very fortunate in my career to start out as a very young faculty member with the first trial of imatinib to now 20 plus years later being here with the approval of ripretinib and avapritinib. So we've gone from having 0 drugs to now having 5 drugs that are approved for use in GIST, which is really exciting for patients. There are still some forms of GIST, though, that we have less things to do. Fortunately, they are much rarer subtypes of GIST, but we still need to sort out what's the best way to take care of these patients. One of them are patients that many years ago we called wild type because they didn't have mutations in KIT or PDFR alpha, but these commonly are tumors of the stomach that have loss of expression of a protein called SDHB. That can happen either through mutation of a family of genes, the SDH family of genes, or sometimes it can happen because of loss of expression of the genes based on abnormal methylation of the promoter of one of the genes, SDHC. That group of tumors is seen more commonly in young patients, or even what we used to call pediatric GIST. But in general, if you look at patients with that class of tumors, they tend to be much younger. Treatment of that type of GIST remains a question. We've looked at imatinib and it really doesn't seem to provide much benefit. Sutent and regorafenib have in studies in which the few patients with this type of GIST that have been identified have their disease controlled, and we think that's because it targets the VEGF receptor pathway. But these patients probably need additional forms of therapy, particularly in some patients where the tumors can be quite aggressive. Fortunately, in many patients, these tumors are rather indolent and don't change much over long periods of time, and many patients live normal lives with their disease and not being limited by it, even off of therapy. Patients with tumors that are associated with neurofibromatosis changes are also a challenge. Some of these patients will have routine KIT and PDFR alpha mutations and will respond to the standard drugs, and that's terrific. But many of them do not. And to date, we have not found a great way of addressing these tumors. Biologically, there's some thought that impacting the RAS pathway, using MEK inhibitors, for example, might be of benefit. But to date, little clinical data to support that, in part just because these patients are uncommon and rare, fortunately. Those are sort of the 2 big groups of patients who we don't have much to offer, or we might think about alternative therapies. I think the other area that we still seek treatment for is patients who progress on standard therapies. For patients who are initially diagnosed and receive adjuvant therapy, we probably are curing some, but could we cure more patients if we had a different approach? Does that approach mean we should be combining therapies that target more than just the KIT pathway, but maybe alternative pathways? What's the role for immunotherapy? Certainly there's been some interesting preclinical work that suggests that there are certain subtypes of GIST that have more immune infiltration, particularly the PDFR alpha mutation GISTs. There is some information in preclinical models that imatinib may activate parts of the immune system, and so maybe combining with immunotherapy might be of benefit. I think these are unanswered questions that are still open for understanding. Are there better ways to deliver effective therapies that we currently are limiting because of side effects? So still lots of unanswered questions, and one of the reasons that I still enjoy getting up every morning and thinking about this disease and how to try and manage it and find more effective therapies for patients.